There we are. Okay. So good morning still. It's not afternoon yet. So let's jump in and talk about our circulatory system, but I want to revisit two concepts of movement of solutes that we talked about in chapter 4. The all famous and ever popular diffusion, and then vesicular transport. So of course, when we're dealing with diffusion, it is a passive process, which means it doesn't require energy, which is good. Okay, we want to use as very little energy as possible to be moving solutes in and out of tissues. So basically, the definition as described here is substances leave or enter the blood according to their concentration gradient. As you recall, diffusion is going to be the movement of a substance from an area of high concentration to low concentration. So let's apply this to the circulatory system. You're going to have respiratory gases like oxygen, all right, our chemical messenger system, hormones, glucose, amino acids, proteins, anything that can be considered nutrients, need to move from your circulatory system, from the blood, into the interstitial fluid, which is the fluid that bathes the tissues. And then eventually from the interstitial fluid, it will move up into the tissues. So that's what we're going to try to do. We're going to try to move stuff from the blood into the tissues. And then at the same time, we're going to have our respiratory gas, carbon dioxide, a waste product of some of our metabolic processes, and other wastes like urea and whatnot that are going to be exiting the cells into the interstitial fluid and then from the fluid back into the blood. So there's an exchange process going on, and we're going to talk about that. So of course, an important thing for us to understand is, all right, how big what we are moving, makes a big difference or deal in how diffusion occurs. Now, we know that simple diffusion, all right, we learned is dependent on two characteristics, okay? Solute has to be really small, okay, and nonpolar. So small solutes can go right through the plasma membranes, therefore go right through the cells themselves, or even in between the cells in what we call the intracellular clefts. But we do have intracellular adhesions that will block that. Okay, but if it's small enough, they can move through that. And so that's what we're going to be discussing. All right, so the movement of these solutes need to be very, very small. Now, if they're larger, no problem. All right, we need to have holes for them to move through. All right, and in some of these blood vessels, when we get to talk about capillaries, there's three categorizations of capillaries, and the last two have to do with the size of the holes that are in the capillaries themselves, in the walls of the capillaries. So we have fenestrated capillaries, and then we have sinusoidal capillaries. So that's basically what we're going to be seeing here, these fenestrations, all right, these openings, or these sinusoids, which are these big gaps, right, in which our larger solutes, proteins will constitute that, but other molecules will as well, that can move through these holes, these gaps, all right, that can move in and out of the capillaries and in and out of the tissues there. All right, so the other, all right, topic is the vesicular transport. Okay, and if you recall, vesicular transport, that will be, all right, an active process. So we will be utilizing ATP, all right, but our endothelial cells, the cells that will line our blood vessels and the lymphatic vessels, right, they're going to utilize pinocytosis. Remember, pinocytosis was the cell drinking, right, very non-selective, and then exocytosis. So pinocytosis is going to be taking stuff in from the outside of the cell. Exocytosis, we're going to be getting rid of material from the inside of the cell and expelling it out of the cell. All right. So when you see pinocytosis, think fluid. And that's what's going to happen. All right, the plasma membrane of these cells will wrap around, all right, some fluid droplets, again, very non-selective, and it will pull, all right, those contents into the cell, and it'll form a transport vesicle. And then those fluid droplets will move somewhere inside the cell. All right, but then if the cell wants to get rid of stuff, it's going to utilize exocytosis. Right, and so exocytosis is going to export or get rid of substances that are inside the cell. Maybe the cell is made, all right, and it will move it to the outside of the cell. All right, so vesicular transport, very important, goes in both directions. Okay, and so we have talked about hormones. We'll talk more about fatty acids in a later chapter when we get into metabolism, right? But hormones and fatty acids are very important in regards to, all right, energy transport and the creation or the making of cholesterol, which is utilized in hormones and bile salts and whatnot. So we'll see how vesicular transport plays a big role. That's going to come later on, so I'm not going to really talk about that. Which leads me to our big topic. Now, bulk flow is important because, again, in chapter 19, right, we discussed the cardiac cycle, how blood during the contraction relaxation process of the cardiac cycle is always going to move from an area of high pressure to low pressure. So here, again, we're going to be dealing with a pressure gradient when we're talking about bulk flow. But basically, bulk flow is us moving, all right, large amounts of fluids and the substances that are dissolved in those fluids. That's what we're talking about. We're going to be moving those items there. And it's dependent on the pressure gradient. Same concept, we're going to always move down the pressure gradient, going down, okay, from an area of high pressure to low pressure. So really, all right, the movement is going to be dependent on the overall, what we call net pressure, because we're going to see opposing forces, and I'll talk to you about what those opposing forces are going to be. Because there's going to be opposing forces. You have forces on the inside of these blood vessels pushing out, and then you have forces on the outside of the blood vessel pushing in. Those are going to be our opposing forces. So we're going to talk about hydrostatic pressure and then what we call colloid pressure, all right? But we'll get into that in a moment. We briefly talked about hydrostatic pressure before, all right, back in chapter 4, all right, when we were talking about blood traveling in a blood vessel, all right, and it was that pressure of the blood pushing on the walls of the blood vessel. Similar to how, all right, the pipes in your house, when water is flowing through those pipes, all right, it's pushing on those pipes. If those pipes are weak, guess what happens? All right, water leaks out of the pipe. All right, so that's the hydrostatic pressure of water. Well, we're going to talk about that hydrostatic pressure for blood. So when we're discussing bulk flow, there's two concepts or terms that you need to have an understanding. One is filtration, and the other one is resorption. Right? So filtration is we're going to move a fluid out of the blood. And resorption is when we're going to move a fluid back into the blood. Okay? So when we're dealing with filtration, all right, the liquid and very small solutes, of course, are going to be able to move, all right, through these capillary openings. Remember, we talked about those, all right, the fenestrated and the sinusoidal. But at the same time, it's going to block large solutes, which is good because we don't want protein, for example, as a large solute, all right, proteins we don't want leaking out of our blood, okay, because some of those proteins are going to attract fluid. And so if the proteins are leaking out of the blood into the tissues, guess where the fluid's going to go? Into the tissues. What are you going to see? All right, from an objective standpoint, you're going to see swelling or what we call edema. So we don't want that. Right? We don't want swelling in our legs and our ankles because proteins have leaked out of our blood vessels. We want to keep those proteins in the blood vessels. So we make sure that those proteins can't get out. So we block those large solutes there. So when we're looking at filtration, right, and as you know, all right, from lab, you are going to see that arteries carry blood away from the heart, and as they move further away from the heart and out to the tissues, they get smaller and smaller and smaller, and they go from arteries, all right, to arterioles, and then eventually from those arterioles, they're going to form what we call capillary beds. And think of capillary beds as the exchange site. They're the smallest of the blood vessels. They're all over the tissues. right? And so that's where we're going to see the exchange of materials. That's where we're going to see, all right, our nutrients, our oxygen, our hormones leaving the bloodstream and going into those tissues, right? And at the same time, we will also see, all right, the removal of carbon dioxide and waste from those tissues going into those capillaries and then being carried away into the venous blood system, going into the venules, then into our veins, and then dumping it back into the heart. So that's basically, you should already know this, all right, that movement pattern there, all right? So filtration, okay, so you'll have your artery or arterial coming in, and then you'll have the big capillary bed. It has all these different routes, right? And then it will come back to a single point again into what we call the venule. So V over here for venule, A over here for arterial, and then in the middle, we've got our CB, capillary bed here, and that's the exchange site. So where we're going to see filtration is going to be over by this end, by the arterial end, right? And then resorption, when all these cells in the by the capillary bed are dumping their waste and carbon dioxide into the bloodstream there, right? We're going to see that more at this end, by the venous end. All right, so filtration and resorption. So filtration stuff's going to be leaving the bloodstream, and then with reabsorption, it's going to be entering into the bloodstream. So let's talk about bulk flow in some terms here. Hydrostatic pressure, okay? The definition is force exerted by a fluid, okay? So that's, like I said, in the pipes of your house, all right, there's a force that the water's exerting, all right, on the walls of the pipe there. Same concept applies to the blood vessels, all right? So we have a term here called the blood hydrostatic pressure, all right? So this is the amount of force that the blood exerts on the vessel wall. Easy, simple, okay? So of course, this will promote filtration, meaning this is going to help move things from the blood into the tissues. That's what we're going to see, all right, with blood hydrostatic pressure, all right? Keep in mind, make sure that you know, all right, the notes there, okay? So we describe blood hydrostatic pressure as HP, subscript B. Then we also have an interstitial fluid hydrostatic pressure. And this is the amount of pressure that the interstitial fluid, all right, exerts on the outside of the blood vessel. So it's trying to push things into the blood vessel. All right, now here's the thing. Pretty much this is zero. Right, so HPIF, IF is interstitial fluid, right? That's pretty much going to be zero. Very little. All right, now the other part of bulk flow has to do with colloid osmotic pressure. Now, if you look at the term colloid, all right, we've talked about that way back in chapter 5 when we were learning about glandular epithelium and how it was producing colloid in our thyroid glands. Colloid is just proteins. So you could say this term as protein osmotic pressure. And then osmotic has to do with water. So basically, when we describe this term, colloid osmotic pressure, we're talking about the amount of pull placed on water due to the presence of proteins, right, in the fluid that we're describing. So, okay, we have to talk about, right, the amount of proteins inside the blood vessel and the amount outside the blood vessel. So, blood colloid osmotic pressure talks about the amount of pull that the proteins in the blood, albumin is a huge one made by the liver, right? How much, all right, pull that these blood proteins have. So they're basically going to suck things into the blood vessel. And if they're going to pull things into the blood vessel, that is resorption. Okay, resorption. So this is an oppositional force. It is going to go opposite, of our hydrostatic pressure. Hydrostatic pressure is pushing things out of the blood vessel, whereas blood colloid osmotic pressure, also known as oncotic pressure, right, is going to pull things into the blood vessel. And that's because, all right, the proteins there have like an attractive force, much like a magnet does on metal shavings. All right, interstitial fluid, colloid osmotic pressure. Again, this is, all right, the fluid draw that is exerted from the interstitial fluid. So the interstitial fluid will have some proteins. Normally, there should be very few, okay? But this is going to be, all right, that pull that the interstitial fluid is going to exert on fluid inside the blood vessel. So since we have such a low number of proteins, all right, this value is very low. Look how low it is, 0 to 5 millimeters of mercury. Hardly worth noting, but still have to note it, okay? Not much. All right, so now that we know these terms, now we're gonna figure out a way to determine what we call our net filtration pressure. You need to memorize, because I can guarantee you this will be on a test, this equation here. All right, so let me interpret this equation for you. The net filtration pressure, which is going to be measured as the net difference of the hydrostatic pressure on the blood vessel wall versus the net colloid or the oncotic pressure that is also exerted on that blood vessel wall. All right, so what does that all mean? Okay, so we're going to determine, all right, we have our net filtration pressure is going to be equal to the hydrostatic pressure of the blood. Okay, that's going to be the pressure pushing out. All right, we're going to take the difference of the hydrostatic pressure that the interstitial fluid is exerting on that blood vessel wall. That's going to be the pressure, all right, pushing inwards because of the interstitial fluid pressure there. But again, that's virtually zero. So we're going to take the difference of those two. Then we're going to subtract, all right, the net colloid osmotic pressure. Again, what we're going to do is we're going to measure the oncotic pressure inside the blood vessel, which is going to be like that pulling attraction. So the colloid osmotic pressure in the blood is going to be pulling stuff into the blood vessel. We're going to take the difference, all right, of the colloid osmotic pressure that is going to be found in the interstitial fluid, which is going to be trying to pull stuff out of the blood, which is close to 0 to 5 millimeters of mercury. All right, so that's what we're going to do. We're just going to take the both values of hydrostatic pressure and both values of the colloid osmotic pressure, take the difference of both of those, and then overall, we're going to subtract the net colloid osmotic pressure from the net hydrostatic pressure. Okay, and so what we'll see is, all right, if it's a positive value, we're going to be favoring filtration. And that's what we should see at the arterial end when we're taking those values here. All right, so when we're looking at the capillary bed, all right, that whole capillary structure there near the arterial end, we should see filtration being favored. So that should be a positive value. All right, and then if we're looking at the venous end, right, that should favor resorption. Okay, so we'll have a larger value, all right, of the overall osmotic pressure. All right, let's take a look here at this picture, and I will show you. Zoom in. Okay, so here you can see, all right, you have a relatively large hydrostatic pressure from the blood pushing out, and then you have a decent sized, all right, colloid osmotic pressure, but we're not going to worry about that yet. So what we're going to, well, I should worry about that because I don't have the values here. Oh, okay, wait, all right. We can see it way down here, all right? So virtually no pressure, sorry, I missed that. It's virtually no pressure from the interstitial fluid pushing, all right, fluid into the blood vessel wall. So we take the difference, right, which is 35 millimeters of mercury. We plug that into our equation here, and then we take the difference of the blood osmotic pressure versus the interstitial osmotic pressure. You'll see the difference here is going to be 14 millimeters of mercury, all right? That's going to give us, all right, our favorable filtration pressure. Then when we slide over here, all right, looking at the venous end here, again, we do the same values. All right, our hydrostatic pressure is dropped quite a bit, all right, as we got to the venous end of our capillary. So it's about 16. You take the difference, all right, that's a net value of 16 millimeters of mercury. Same thing here with the colloid osmotic pressure. All right, we see it's a little bit higher over here. All right, so we take that difference, okay, when we get our 21 millimeters of mercury, all right, and we take the overall value, it's a negative value, so we're going to be favoring resorption. And so that's what that picture here is basically showing you here. All right, as we move across the capillary, the hydrostatic pressure of the blood vessel drops significantly. We go from favoring, all right, filtration to favoring resorption. Positive value, filtration, negative value, resorption. And that's how it should be. Now, our lymphatic system, we'll talk about the lymphatic system in a different chapter here. Not all of that fluid that gets pushed out of the capillary gets resorbed, right? And so, unfortunately, about 15% of it doesn't. No problem. We got the lymphatic system, okay, it's like our backup, right, that is going to pick up that excess fluid, right, and eventually return that excess fluid, all right, to our circulatory system, okay, and it dumps it into venous circulation, and that's going to be close to the heart. And we'll talk about that when we talk about the lymphatic system, okay? So just think of it, its job is to pick up excess fluid that's been dumped into your tissues that did not get resorbed by the capillary bed, all right? And so we're going to eventually get that fluid back into our venous circulation. All right, so let's talk about our local blood flow. Local blood flow. All right, so this is when we're basically looking at the structures in and around our capillary bed. Okay, so we're going to discuss the arterioles and the venules too. Okay, so what we're going to see is, and this is very important, not all of the capillary beds or capillaries in your body are going to be full at the same time. It varies, right? And there's a couple, and we're going to talk about these variables, like what causes, all right, blood flow to certain area, all right, to be different than blood flow or capillary flow to another area. All right, so we're going to go check all this stuff out. So how we measure flow is going to be a volume, okay? So we're going to use millimeters over time, okay? So millimeters per minute. And you're going to see this term here called perfusion. This is a very important term. We're going to use it quite a bit throughout this chapter. All right. Perfusion is basically just getting blood to bathe those tissues. All right. So that's basically what we need to do. We have to make sure that blood flow, that flow is going to be enough to provide adequate blood, which has the nutrients and all that, and the means of removing wastes, okay, from the tissue. We have to maintain that adequate perfusion. So 4 things that our local blood flow is dependent on. 1, how much blood vessels are going to be in that area, okay? Next, how our smooth muscles are going to respond, all right, depending on the amount of blood that is needed, all right, for whatever metabolism that's going on, all right. Then we have our local regulatory factors that are going to alter the blood flow, and we'll talk about that. and then a term called total blood flow. So here are those four things. We're going to hit each one of these now. Okay. First one is the degree of vascularization. Now, we learned back in chapter 5 that various tissues have different degrees of vascularity. For example, all right, areolar connective tissue, which is a loose connective tissue, is very vascularized. Bone has lots of blood vessels in it. You wouldn't think, but it does. Okay. Certain tissues like dense, regular connective tissue is going to have poor vascularity. That's tendons and ligaments. All right. Some of it, well, perfect example, epithelia, that is avascular. Epithelial tissue, those cells are so closely packed that there's no room for blood vessels. Same thing with mature cartilage, that's also, all right, avascular. So certain tissues will have lots of vascularity. You can see the examples there, brain for obvious reasons, skeletal muscle, all right. If you're an athlete, you're going to have lots of blood vessels going there, of course, the heart and then the liver. So we're going to see, depending on the tissue, we'll either have high vascularity or little to no vascularity. So that's important. So this is a term called angiogenesis. Genesis is to create or make, right? When we're talking about angiogenesis, we're talking about the formation of new blood vessels. All right, now this is not something that just happens overnight. It takes some time. Again, it really depends on the type of tissue. So what we're going to see is if a tissue starts to demand, all right, more blood flow, all right, our exercising athletes, as they're training and they're getting great at whatever they're doing, all right, we will need to see an increase in that potential perfusion because we need to supply those tissues with more blood to meet their metabolic demands. So this starts to occur. I won't go into the details, okay, but you'll start to see the formation of new blood vessels, right? All the time in skeletal muscle tissue, all right? Believe it or not, in adipose tissue with substantial weight gain, all right, you will see an increase in vascularity because adipose, all right, your body considers it to be an important tissue because it stores energy. And it also does cushioning, which is a protective factor in insulation. But for the energy, it needs to access that energy. Right, so we need to have blood vessels in close proximity in case we need to access that energy. All right, and then of course, in our blood vessels of the heart, the coronary vessels, right, we see this quite a bit with blockage, right, how you'll see the formation of new blood vessels to create an alternate route for that blood to travel so we don't get ischemia. All right, so that's angiogenesis. What about regression? All right, so you know the saying, what goes up must come down, okay? So say that person that gained all that weight and increased their angiogenesis goes on the Atkins diet or Weight Watchers and they start to lose weight, right? So what will happen is they'll eventually return to that previous state of the blood vessels. Because now no longer do they have that extra tissue, all right? So those vessels that they grew start to regress. Same thing happens with an athlete when they're done with their prime. They've just completed all their Olympic training. The Olympics are over. There's their last year. So now they're no longer training like they used to, and they become more sedentary. Same thing happens. All right, so this is an important concept because when we look at certain cancers, all right, tumor angiogenesis, we'll see that cancerous cells are no different than any other cell in your body. They need nutrients, all right, to survive, to grow. And that's what cancer does. It wants to create new abnormal cancerous cells, and it wants to keep growing. So the same thing happens. Its requirements are no different. So it is going to trigger, all right, the release of these chemicals, all right, these locally acting hormones that are going to stimulate the growth of new blood vessels. And as it gets more blood, then the tumor itself can grow, and it will perpetuate this cycle. So for years, we have been trying to design certain drugs that prevent the growth, right, of blood vessels to these cancerous cells. So essentially, we try to starve them out, and so prohibiting their growth and their spread. All right, the second factor when we're talking about local blood flow is myogenic response. Myo is muscle, so that's what we're going to see. We're going to be looking at the smooth muscle in these blood vessels. And the smooth muscle, you know what muscle does, it contracts and it relaxes. When it's around a blood vessel, when it contracts, it causes vasoconstriction, right? And vice versa. When it relaxes, it causes vasodilation. So this myogenic response, its job is to keep that blood flow to that area constant, all right? Constant. So let's look at two scenarios here. If your overall blood pressure rises, all right, we're going to see more blood entering into the arteriole. As a result of this, it's going to create a stretch on the blood vessel wall. So in response to that stretch, the smooth muscle in that wall will contract. And that contraction will decrease blood flow, okay? So we can return back to the original levels. Kind of cool, right? So there's a quick, as blood pressure increases, there's a quick increase in blood flow for a moment to that area, all right? And so, all right, the smooth muscle cells in the arteriole will contract because they're being stretched, they'll contract, and it will cause vasoconstriction, which will decrease that blood flow to the area back to the original levels. Remember, homeostasis, we want to keep everything functioning normally and optimally. All right, so when things get turned up too high, all right, we're going to try to put them right back into the middle again. So conversely, if the systemic blood pressure decreases, that means less blood will be coming into the arteriole. That means less stretch, right? And so what we're going to see is the smooth muscle cells around the blood vessel are going to relax, causing vasodilation. That vasodilation will increase the blood flow back to original levels. And so it's constantly doing this, tweaking, depending on what your blood pressure is doing. All right, it's a form of that negative feedback loop that we talked about. All right, stimulus is an increase in blood flow. All right, our result is going to be a decrease in blood flow, always back to the original levels. Okay. All right. Then, all right, what we're going to be talking about is our blood flow that is locally regulated. So what happens on a local level? All right, well, this is based on need. This is important. It's all based on need. All right, so depending on what kind of tissue we're talking about, all right, or what that tissue is doing, all right, say there's a change in the metabolic activity. For example, all right, your skeletal muscles, when you start to exercise, when they're exercising, their metabolic activity changes and their need for oxygen and glucose and anything they can use for energy increases. Or we'll see this based on need if the tissue is damaged. All right, so we have our vasoactive chemicals. These are the chemicals that are going to cause changes again in the blood vessels to either become bigger or smaller. Okay, so we have our vasodilators, and that term you should know by now. Vasodilators are going to cause the arterioles, all right, to dilate. And when that happens, all right, we will get more blood flow into the capillary beds. All right, hold on one second. I don't have it on the slideshow. It's in your lab. There's a picture, all right, in your lab of a capillary bed. You got an arteriole on one side, and then a venule on the other. And you got one single capillary with all these little branches that come off. All right, and at the beginning of the capillary, and what we call the precapillary sphincters, you have these smooth muscle cells that wrap around, all right, the capillary there. And so they can pretty much occlude the capillary bed, just pretty much shut it down. You'll have them on these little branches here and over here, all right? And so what they'll do is, all right, depending on what's going on, all right, those, if we're undergoing vasodilator chemical release here, we get that dilation of the arterioles, which will increase blood flow, and we get relaxation of those precapillary sphincters, which are just smooth muscle cells, right? If they are all relaxed, right, everything is dilated, then we can get an increase in blood flow into the capillary beds. Whereas those vasoconstrictors, all right, they'll constrict, all right, in the same way, not the same way, all right, but depending on what's happening, all right, if there's a decrease, we don't really need blood going to that area because those tissues aren't really doing anything. That is an increase in metabolic demand or damage there, okay? We'll see a constriction in the arterioles, so that in itself will decrease the blood flow, right? And we'll also see a contraction in those precapillary sphincters, which will then decrease blood flow to that area. So maybe we can use that blood to go somewhere else. Maybe it's needed in other tissues. All right, so we have this term here called autoregulation. We're still talking about what's going on in the immediate area, the local short-term regulation. Autoregulation is based on, all right, our metabolic activity, which can be changing, right? And so the tissue itself is going to control, all right, the amount of blood that goes to that area. So, like I mentioned before, we increase the activity, all right, of that tissue. And so because of that, all right, we are going to release, all right, certain substances. For example, all right, you will see in the case that our activity has increased, maybe we need to get more blood flow. And so because of that need, all right, what will happen is we will have our vasodilators, like oxygen will help to vasodilate, because as those tissues start to go through, all right, oxygen and any nutrients that, like glucose, for example, as that starts to drop off, all right, that will then send a signal out that, hey, we need more blood flow to this area so we can get more oxygen to undergo whatever metabolic function that we're doing. Hey, we need more glucose. Our ATP levels are getting low over here. Or at the same time, right, we'll see an increase in carbon dioxide levels because that's a waste product of metabolic activity. We'll start to get an increase in lactic acid. We see that in muscles all the time. Hydrogen ions, all right, that is going to decrease the pH value. And then, of course, we'll see an increase in potassium levels. So all of these things, all right, will act as a stimuli to tell, all right, the tissue in the area that we don't have enough perfusion going on. And so as a result of that, that will act as vasodilators and cause an increase in blood flow. So again, we're basing this on that negative feedback. So as our perfusion starts to increase, then we'll see the blood vessels in that area start to constrict. Now there's a term here, because we're talking about autoregulation, called reactive hyperemia. All right, when we're talking about hyperemia, we're talking about increased blood flow. So what reactive hyperemia is, and you may have seen this before, all right, in which you get an increased amount of blood flow to an area in which the blood flow to that area was halted or temporarily disrupted. And so the perfect example is when you walk in, well, we don't really see it too much down here. Well, maybe around this time of year. But if you're living up north, like in Alaska, in the middle of the wintertime, and you're outside brushing snow off your car, and you've been out there for 20 minutes, and it's 2 degrees outside, and you walk into your house, which happens to be 82 degrees, as soon as you walk in, all right, your face is red. And the reason why is, all right, you've had a decreased amount of blood flow to that area there. And then as soon as you're able to get into a different environment, all right, we need to resupply all those nutrients and oxygen to that tissue in which the blood supply was halted or significantly disrupted. And so as soon as you walk in, boom, all right, vasodilation on a mass scale occurs, blood is going everywhere, and you'll see, that person's face go from pale, all right, to red. All right, so what do we see here with tissue damage? We're talking about our short term, or we're talking about our defense system, our immune response. Inflammation is a perfect example. All right, so inflammation is part of the normal healing process. And so what we'll see is, all right, during that time of inflammation, because you're responding to damaged tissue, you're going to have several cells on hand that are going to release our vasoactive chemicals. All right, histamine is a perfect example. All right, it causes our blood vessels to become leaky. We'll see dilation of the arterioles here. All right, there's this other substance here called bradykinin. It does a whole bunch of things, all right, but it too contributes to dilation. All right, so we'll see, all right, histamine, we're always thinking of allergic reactions when we're talking about the release of histamine, all right, but these chemicals will be released based on either injury from trauma, an allergic reaction, some sort of infection, and even during exercise. Because again, during exercise, we want dilation of blood vessels to increase flow. Right? And in some cases, we'll see the release of nitric oxide from the plasma membranes of cells, of the endothelial cells, and that too will act as a vasodilator. Right? Because again, when we get vasodilation, we increase flow, and then we can get whatever we need, especially if it's an infection. White blood cells are in the bloodstream. We need to get them to the site in which the infection is present, right? And in some cases too, when we're talking about tissue damage, right, we're going to see the release of our vasoconstrictors. Again, why? Because we want to prevent blood loss. So we'll get our prostaglandins and thromboxanes. We talked about the prostaglandins before, right? And how you have cells releasing, all right, these chemicals to prevent clotting, but when they stop, all right, you'll see, all right, how in some cases, well, scratch that. Let's just go with the straight up. You have damaged tissue, all right, you're going to have that damaged tissue releasing these chemicals as a chemotaxis, a way to attract, all right, the cells that are going to be responsible for causing blood clotting, all right? And so that's what we're going to see here. And at the same time, they're going to cause vasoconstriction to reduce the amount of blood flow to that area. And then finally, our last factor, right, when we're talking about the blood flow through the capillary beds and whatnot, is the total blood flow, right? And then when we're talking about total blood flow, we're talking about, all right, how much blood is being transported through that vessel, all right, over our unit of time, which is usually about a minute. Okay, interesting fact, it's going to be equal to cardiac output, which is about 5.25 liters per minute. So if our cardiac output increases, so should total blood flow. And we'll see that during exercise. All right, your cardiac output could go up to 7, all right, liters per minute, up to 8 liters, okay? So what we're going to see is, all right, if one increases, so will the other, because we need to make more blood available to the tissues, because, all right, if you're exercising, obviously the metabolic demands of those tissues have increased, all right? So when we're talking about total blood flow, we're going to be discussing 2 components. One, what's going on with the blood vessels, and then also what's the heart doing. All right, we talked a little bit about it in chapter 19 about, you know, how to increase cardiac output and how to decrease cardiac output. All right, if you recall, cardiac output is equal to the heart rate times the stroke volume. All right, so that is going to be the variables, all right, and how to increase the cardiac output. And then we talked about what causes an increase in stroke volume. All right, we talked about all those 3 different factors there. I remember chronotropic agents and all that fun stuff. All right, and then we talked about what increases the heart rate when we're dealing with, all right, the sympathetic nervous system. We'll touch on some of that here. So here, all right, I wanted to show you this picture, all right, showing us blood pressure and then what blood pressure is doing in certain vessels, meaning what is it doing in the arteries, what is it doing in the veins and in the capillaries. So this graph here, and I'll refer to this throughout the chapter here, what you're seeing is, you might notice, all right, that the pressure for blood pressure is different during times of systole, that's when the heart is contracting, systolic pressure, and then times of diastole, which is when the heart is relaxing, right? So you'll notice, right, when we're in the aorta, the arteries, and even the arterioles, there's a difference. You can see, right? It's obviously going to be higher when the heart is contracting and lower when the heart is relaxing. But you'll notice as we go from the large blood vessels, all right, towards the smaller blood vessels, that difference becomes smaller and smaller and smaller. Then when we get to the capillaries and the venules and the veins and the vena cava, there's no difference. All right, so I'll describe all that to you. We'll talk about it, okay? But I just want you to understand that there is a difference. So let's talk about what's going on, all right, in the arteries, all right, when it comes to blood pressure. So there's this term here, and you saw it on the slide before, called MAP, all right? And that stands for mean arterial pressure. And so if you're familiar with math, okay, the mean is the average. So what we're seeing here is the average arterial blood pressure during the cardiac cycle, which is the lub-dub, okay? So when the heart contracts and relaxes, right, what happens? What is our average arterial blood pressure? All right, a couple factors to keep in mind. All right, distally is going to be longer than systole, so the mean should be closer to the diastolic pressure. And you kind of see that in the graph. Here's the map, all right? And you'll see that it's closer to the diastolic pressure than it is to the systolic pressure. Systolic pressure is way up here, and the map is down here. That's what we're referring to. So here's another equation you should be memorizing. Put this in your brain, all right? The mean arterial pressure is equal to the diastolic pressure plus 1/3 of pulse pressure. What's pulse pressure? No problem. Let me show you. Pulse pressure is the difference between the systolic pressure and the diastolic pressure. So the example you can see here for values is 120 is for systolic pressure and 80 for the diastolic pressure. So that's what we're going to do. We're going to take the difference there, which is 40, all right? And then we're going to divide it by 3. Because that's what this is saying. Diastolic pressure plus 1/3 of the pulse pressure. And this is how we determine 1/3 of the pulse pressure. This is going back to fractions, y'all. All right. 40/1 times 1/3. That's how we're going to determine the pulse pressure there. Or divided, excuse me, not times. Sorry, my bad. Okay, so that's what we're going to do. So the blood pressure is 120. So we're going to determine our pulse pressure from that by subtracting 80 from 120, and that gives us 40. Then we're going to take 1/3 of 40, all right, and that is about 13. Check your calculator, divide 40 by 3. It's like 13 point something. All right, and so then we're just going to add that value of 80. Why? Why is that? Why do we use 80? Because that's the diastolic pressure. And where do I find that value? Right here. There is our blood pressure. Blood pressure is the systolic pressure over the diastolic pressure. Right? The larger number is the systolic pressure. When you're taking blood pressure values, the lower number is going to be the diastolic pressure. Okay? So again, this gives us an idea of perfusion. So in general, if our MAP is going to be below 60, you have insufficient blood flow. If it's above 60, okay, then you have sufficient blood flow in general, okay? So that's going to be what we're going to see in our arterial areas. What about the capillary blood pressure? Important fact, all right? We saw on our graph again how, all right, there is, all right, a fluctuation. That's what these lines are showing you. There's a fluctuation in the blood flow dependent on systole or diastole. But you'll notice there's no fluctuation down here in the smaller vessels. And that's what we're going to see. When we're in the capillaries, okay, we're no longer going to have a fluctuation between systole and diastole. It's smooth, which is good. That's what we want. Nice, smooth movements, all right, and pressure for blood flowing, okay? So both flow and pressure are going to be smooth here because we're not getting fluctuations in our systolic and diastolic pressures there, which is good because we want that, both of those values, both flow and pressure, to be high enough so we can get an exchange of substances, so we can get oxygen out of the blood and glucose out of the blood, and so we can get carbon dioxide into the blood and wastes into the blood, all right? But we don't want it to be, all right, too high, all right, or not, well, we want it to be low enough as to not cause blood vessel damage. All right, high blood pressure is bad. Ask anybody, ask any cardiologist. Their first concern is damage to the blood vessels, because that's what starts conditions like atherosclerosis, right? That plaquing. You have to have damage to the blood vessel, and then that plaque can build up on that damaged area. Okay, so when we're looking at the capillary blood pressure, we give a value, all right, at the arterial end of 40 millimeters of mercury. At the venous end, that value is going to be below 20 millimeters of mercury. If you don't believe me, go to your graph here. All right, here you can see, where is that? You can see here the pressure at the arterial end is close to 40, and at the venous end, it's around 20. Okay, so that pressure drops along the capillary, which also, again, if you think about it, remember what I said, at the arterial end of our capillary, that favors filtration. We want that pressure to be high enough to push stuff out of the blood. And then at the venous end, we want it to be low enough, all right, so it's not opposing things trying to get into the bloodstream from the tissues, right? So we can absorb those wastes and carbon dioxide, right? So that's why filtration at the arterial end, resorption at the venous end. All right, then, all right, when we get past the capillary, we're going to get into our venous or the vein system here. We got to take into consideration our venous blood pressure. Remember venous return? We talked about in chapter 19, all right, how much blood comes back to the heart. So venous return, all right, is dependent on three things. We're going to talk about those three things. Of course, the pressure gradient, moving from an area of high pressure to low pressure, all right? The skeletal muscle pump, pretty cool. And then the respiratory pump, that's really cool. So again, we go back and look at that graph, you know it's one single line, okay? It's not this over here, this is pulsatile. Okay, so when we get into the venous portion, all right, the venous pressure is going to be very low and not, that's important, pulsatile. Your veins don't have a pulse. Your arteries do. You don't take your pulse on veins, you take it on arteries. All right, so when we're looking at the pressure gradient, that's the difference in pressure. All right, look, it's at 20 millimeters of mercury in the venules right here. Here you can see it. That's that smaller circle right there. That is the pulse pressure for the veins. Blood pressure is on the X or Y axis, and then our the size of the vessels is on the X axis here in our graph. right? And you can see that that pressure just keeps dropping as we move along our graph here. See, it goes from 20 and then it just keeps going down. We get into the actual veins. Now we're closer to 10 and we get all the way to the vena cava. It's virtually 0. And so that's what, so again, blood is going to flow from an area of high pressure to low pressure. So from the venules, it's going to travel to the vena cava because that pulse pressure, that gradient keeps dropping. So it's going to always want to move towards an area of lower pressure. And our pressure in the vena cava is 0. All right, so that's one way, all right, that we get blood to the heart. One is that pressure gradient. As that pressure gradient is dropping, it's always going to move from an area of high pressure to low pressure. And so as we go from the capillaries towards the vena cava, that pressure gradient gets smaller and smaller and smaller. So our skeletal muscles also help to pump blood, all right, from our limbs to the heart. So as the muscles contract and relax, that squeezes the veins. Veins have valves, and we know the jobs of the valves are to prevent backflow, ever forward, never going backwards. And the same is for the veins as it was in the heart. So the veins are only going to move blood to the heart. So as they contract and relax, the blood will be trapped in those valves until it gets contracted and pushed again, and then it pushes it forward towards the heart. So we see this process happen faster during exercise, all right? And that's why you've heard when you're on an airplane, especially if you're flying like from here to Australia, okay, and you'll have a 14-hour flight in there somewhere, right? They want you, okay, to get up and walk around. Because if you're not moving, all right, the blood that are in those veins just sits there. But when you get up and start walking around, your leg muscles contract and relax, and that squeezes on the veins and it moves the blood forward, like in this picture here. So you can see as these muscles contract, blood can go in one of two directions, up or down. Well, it can go down, but it stops at the closed valve. It can't go any further. All right, but it can go up, and again, these valves open in one direction only, and that is to the heart. Skeletal muscle pump. All right, the respiratory pump, similar. All right, this is going to be during inspiration and expiration. And of course, we're going to be dealing with our pressure gradient. So I'll go through that with you here. All right, so this is the third way that we can get blood to go into the heart. So when you are taking a breath in, the diaphragm contracts and it drops down and it pushes down into the abdomen. Okay, it will essentially becomes flat. All right, so what happens is the pressure inside of your abdomen, the abdominal pressure, increases. And the pressure inside your thorax will decrease. So since you have greater pressure in the abdominal area and less pressure in the thorax, all right, the blood is going to flow from the abdomen into your thoracic cavity. Now that's an important concept when you get into the respiratory chapter, all right, because that's going to allow air to enter into your thorax. We'll talk about that, all right? We'll wait on that when we get into the respiratory system. So when you expire, when you exhale, the diaphragm relaxes, all right? And then what we're going to see is the thoracic pressure is going to increase and the abdominal pressure decreases. And so what we're going to see is any blood that was in the thoracic cavity at that point goes into the heart. And then because the abdominal pressure decreases, that allows blood that was in your lower limbs to move into the abdominal veins. All right, so as you can tell then, if we increase your respiration, normal respiration is roughly about, the range is 12 to 20 breaths per minute, on average about 16. All right, so if you go up to 25 breaths per minute, all right, then you are going to increase the blood movement via the respiratory pump. increase in respiration, increase in respiratory pump, which is good because that gives us more blood returning to the heart for whatever reason, usually if you're exercising. All right, so again, pressure gradient plays an important role. I can't stress enough how important it is for you to know what the pressure gradient is, right, when we're talking about movement of blood in the heart during the cardiac cycle, and then movement of blood right here when we were talking about blood pressure and its effect in the various blood vessels of your circulatory system here. Okay, so keep in mind, inspiration is going to increase blood flow into the thoracic veins, whereas expiration is going to increase blood flow into the heart and into the abdominal veins. Okay, so let's talk about now how this pressure gradient is going to affect the systemic circulation here. All right, so if we look, again, going back to that graph, all right, our mean arterial pressure, all right, is going to be, after we calculated it out, all right, it's going to be, all right, 93 millimeters of mercury. All right, and then when we look at the arterial pressure in the vena cava down in here, that's virtually 0. Okay, so 93 mean arterial pressure and 0 for the vena cava. So just by knowing that, all right, that pressure gradient again, right? That's that difference between the arteries and the vena cava, which is that blood vessel that leads right into the heart. So the pressure of the arteries right outside the heart in the aorta, all right, and those larger blood vessels is 93 millimeters of mercury. And then that blood pressure in the vena cava is 0. So knowing that, it's going to go from an area of high pressure to low pressure. That's how we're seeing, all right, how blood is traveling through our vascular system there. It is going to travel, all right, down that pressure gradient. So if we increase the gradient, then we're going to increase total blood flow. So if we increase the difference from 93, say now you start to exercise, your blood pressure goes up now because you're exercising, and now the mean arterial pressure is not 93, but say it's 103. Okay, so if we've increased it that much, we're going to increase the blood flow. Okay, so this is important. That gradient is going to be increased by an increase in cardiac output. Know that. Know that, know that, know that. How do we increase the cardiac output? Well, you should know the equation. Cardiac output is equal to heart rate times stroke volume. All right, so if you increase either one of those values for cardiac output or both, right, that means you're going to increase the pressure gradient. You make the heartbeat faster. That's going to increase the pressure gradient, right? If you start to increase the amount of stroke volume, you go from 60 to 70 milliliters of mercury per heartbeat to 80 or 90, okay? That increases cardiac output. That increases the pressure gradient. And when you increase the pressure gradient, you increase the total blood flow. I can't stress to you how important that concept is. You need to know that. All right, so this leads me to resistance. All right, remember when we talked about the heart, we talked about afterload, right? What's waiting on the outside of the heart, all right, from all the blood vessels out there? Well, we're going to talk about one of those concepts here, resistance. Resistance is friction that your blood is going to encounter as it's flowing through the blood vessels, right? And you know what friction is. I mean, you rely on it when you're driving your car, right? The friction of the rubber of the tires on the road, especially when you're driving in wet or snowy conditions, plays a big role, okay? Well, in this case, friction, all right, is going to be, all right, that to which we measure the resistance as blood contacts blood vessel wall. Important concept because it opposes blood flow. It's not good for blood flow. The more friction, the more resistance, right? The less blood flow. All right, so please keep that in mind. So when we talk about peripheral resistance, we're referring to, all right, the resistance that blood has in the blood vessels. All right, so there's a couple things that are going to affect resistance. We're going to talk about those. One is viscosity, how thick your blood is. All right, it's easier to pump blood when it's more liquidy than it is like Jello. Okay, try swimming through Jello. I'd rather swim through water than Jello. All right, vessel length, how long, and the lumen size. Is it constricted or is it dilated? So blood viscosity, that is going to impact flow. So the thicker the blood is, the more viscous it is, that's going to raise your resistance. And that's heavily dependent on what is in your blood. Right? Of course, you have the normal formed elements. We're going to include all the cells. All right, that's a huge part. So when we're looking at that, all right, in normal blood, all right, our blood is going to be 5 times more viscous than water. So the ratio of formed blood elements to like your blood plasma to water, okay, is going to play an important role. So our viscosity, the thickness of our blood, will decrease in people that are anemic, because anemia, folks have a decrease in their erythrocytes for whatever reason. There's several causes for anemia. One of the more popular ones is IDA, iron deficiency anemia. Okay, if you're deficient in iron, you're not going to be able to form, all right, red blood cells as effectively. There's pernicious, there's a whole bunch of different kinds. All right, so that's going to be people with a low blood cell count. Now you can see that viscosity will increase in situations where someone has gone and done blood doping. And if you know what blood doping is, that's when you draw blood, your own blood, you store it, okay, for a while before. It's usually athletes that do this. In fact, I can't think of anybody else that does blood doping other than athletes. And then they put the blood that they took out back into their body. And that helps to increase their red blood cell count so they can have a larger oxygen supply. Unfortunately, by doing that, that makes your blood much more thick. Okay, that's not good. Or dehydration. Less water in the blood plasma means that ratio of the water and blood plasma to the formed elements is not in favor of water, but in favor of the blood formed elements there. And so the blood will be thicker because you have a larger percentage of those red blood cells, white blood cells, and whatnot. So that's viscosity. Basically turning your blood, if you increase viscosity, you're turning your blood more into sludge. All right, vessel length, all right, the longer the blood vessels are, the more resistance you will see, okay, because that friction occurs down the entire length of the blood vessel, right? So if it's longer, you're going to encounter more resistance. If it's shorter, less resistance, all right? So if things are good and nothing's really changed in your body, then your blood vessel length will remain constant. But if you gain weight, okay, if you gain a lot of adipose tissue, what did we say? Adipose tissue will get a higher level of vascularity because you're going to be growing all those new blood vessels. So you're going to increase the blood vessel length. That is going to increase resistance. Same thing when you lose weight, all right, for that adipose tissue, all right? Those blood vessels will decrease. Right? Or again, if you become sedentary and you're no longer exercising like you once did, then all of those new blood vessels that you formed along your skeletal muscles will start to regress. So we'll see with angiogenesis, people with angiogenesis, increase resistance. All right. And then we'll see, all right, people with vessel regression, decrease resistance. That's vessel length. Then finally, vessel radius. Smaller radius, more resistance. Okay, vasoconstriction basically causes more resistance. See, blood likes to flow through the blood vessel in what we call a laminar flow, just like this. Okay, but that's in the center of our blood vessel. All right, which is good. Center of the blood vessel and the center of the lumen, it's nice and laminar. When we get to the edges here, what will happen is the blood will encounter what we call these eddy currents. All right, and it will basically bounce and bang into the blood vessel wall. And that causes friction, that causes resistance there. So the larger the blood vessel, fewer eddy currents, less resistance. The smaller the blood vessel, you don't have as much room for laminar flow at the center, and we'll see a lot more resistance on the periphery here. It's tough to move the mouse to show you, okay? But that's what we're seeing. Okay, so blood will flow faster in the center, slower at the periphery because of that resistance. So in order to decrease resistance, we increase diameter. When we increase diameter, all right, we decrease the resistance, and therefore our blood flow will increase. Okay, so we can say, all right, you will have, all right, more flow in a vessel that's dilated compared to a vessel that's constricted. So we have an equation for that. Flow is proportional to the radius to the fourth power. That's what this means here. Okay, so flow is the F, all right, that symbol there is showing us the proportionality to the radius. So if we increase our radius from 1 millimeter to 2 millimeters, not a huge change, but basically we're making, all right, the inside of our blood vessel bigger. Okay, and so by doing that, all right, we can increase the flow by 16 times. Pretty impressive. All right, so that brings me to this total blood flow, the amount of blood that's going to be moving through our system, again, per unit of time, right? That's going to be important. All right, so flow is proportional to the pressure gradient divided by resistance. So that pressure gradient, everything I was telling you about, that mean arterial pressure, all right, by the arteries compared to the vena cava, and then resistance. And that just includes those three factors that I talked to you about: viscosity, vessel length, or the lumen diameter there. Okay, so when we talk about the systemic blood pressure gradient, that's what we're referring to. The triangle refers to a change, right? So basically, I said this before, as the gradient increases, that pressure gradient increases, our total blood flow will increase. And again, to reiterate, that gradient is generally increased by increasing the cardiac output. So take into consideration what the heart is doing. It's not the only thing, but it definitely is part of this system here. All right, now when we're looking at resistance, all right, if we increase resistance, we're going to decrease blood flow. If we make our blood more viscous, right? If we have much more blood vessels in the total systemic circulatory system, you're going to make that longer, you're going to increase resistance. If those blood vessels are vasoconstricting, they're going to increase resistance. All right. So keep in mind that equation. This is another equation you need to know. Okay. Flow is going to be dependent or proportional to the pressure gradient divided by resistance. So if the pressure gradient stays the same, how do I determine the pressure gradient? See what the map is, the mean arterial pressure is going to be, and then see what the venous pressure is going to be. And usually it's going to be the vena cava, which is 0, right? So if the pressure is going to be 93, and that stays constant, and we're going to divide that by the resistance. So say resistance is normally measured at 2, for example. All right, then we see how the resistance then has increased because there's been significant vasoconstriction, and it brings our resistance value up to 8. Do it on your calculator. 93 divided by 2 is going to be larger than 93 divided by 8, if you don't believe me. So that means if we've increased the resistance, we have decreased the flow. Again, there is some math involved in this, okay? So you can see this picture on 2013, all right, how total blood flow is proportional to the pressure gradient. And remember, our pressure gradient is going to be determined by our cardiac output. All right, so you can see here, right, an increase in cardiac output, say your heart rate's increased or your stroke volume increases or both, you'll see, all right, this is the normal, and then now it's increased to that solid red line. You can see the gradient has become steeper. So that's going to increase our total blood flow. And then this picture here shows us for resistance, vasodilation. Vasodilation increases blood flow, okay? Then you can see the factors that are going to decrease our blood flow. If our cardiac output decreases, say your heart starts to beat less, or your stroke volume becomes less. Now our pressure gradient has dropped down, and the slope there is much less, so it is a smaller pressure gradient, okay? That is one way to decrease total blood flow. Or we can increase the resistance, say vasoconstriction, say being dehydrated, making our blood thicker, okay? Or you've gained a significant amount of weight in 6 months and you went from 20 pounds of adipose tissue to 120 pounds of adipose tissue, and all those new blood vessels that had to form because of that, you've increased the vessel length. All right, so how do we regulate blood pressure? Okay, obviously, all right, back in chapter 1, we learned about homeostasis, optimal performance, all right, that quote unquote healthy, all right, zone that we want to be in. Well, we want to keep our blood pressure within a certain range. Right now, the values are listed as 90/60. Right? 90/60, 140/90. That's the range. So on average, okay, it's 120/80. That's the range that we want to keep it at, 90/60 to 140/90. It's close to 120/80 as possible. This allows us, folks, okay, for that tissue perfusion. All right, again, we want it to be high enough so we can get that tissue perfusion, so we can get that filtration going at proper levels, so we can get that resorption going at proper levels, but we don't want to damage the blood vessels, not too high. So when we talk about blood pressure, we're going to be looking at cardiac output, resistance, and then blood volume. All right, so that's going to be regulated by your control system, both the nervous and the endocrine system. All right, so that's very important that you understand that. So let's look at how our nervous system is going to there we go. Okay, how the nervous system is going to affect all of this. All right, autonomic reflexes are going to be what regulates your blood pressure in the short term. Short term. Right? So if we're going to be dealing with the nervous system, we've got to go to the brainstem, specifically to the medulla oblongata. Right? So the medulla oblongata, this is where we're going to have our cardiovascular center, which is going to be made up of the cardiac center, which we talked about. All right, the cardio-acceleratory and cardiac inhibitory portions. And then we haven't talked about it yet this semester, the vasomotor center. Both of those are located in the medulla oblongata. One's going to deal with the heart. All right. Well, no, I'm not going to talk about that. Well, I will. Hold on one second. All right. So of course, all right, here in the cardiovascular center, we can make alterations to our cardiac output, to resistance, or to both of them. All right, so cardiac center is going to be what is going to influence our blood pressure through what the heart does, through cardiac output. The vasomotor is going to influence our blood pressure simply by altering the diameter of the blood vessels, either through constriction or dilation. Okay, constriction or dilation. So, quick review: cardiac center. We've got our two nuclei here, the cardioacceleratory center that deals with the sympathetic nervous system. Cardioinhibitory, the parasympathetic. Cardioacceleratory is going to send through T1 through T5, all right, through those nerve segments, all right, out to the SA node and the heart wall. Those nerve fibers will go out there, and they are going to increase both heart rate and the force of contraction. By doing so, it will increase cardiac output, therefore increasing blood pressure. Another equation that I think you should know, you don't have to know it for any tests, but blood pressure can also be calculated out by heart rate times what we call, total peripheral resistance. Okay, that's one of the ways that you can actually calculate out blood pressure. And as you can see, if we increase the cardiac output by increasing the heart rate, that's also going to affect our blood pressure according to that equation. Okay. Now, the cardioinhibitory center deals with the parasympathetic nervous system. And as we know, we're going to use the vagus nerves, cranial nerve 10. And we have the vagus nerve affecting both the SA node and the AV node. And it's going to slow things down by decreasing the heart rate, but it also slows conduction signals. Remember, the AV node will slow things down. That's our bottleneck. That's to make sure that the ventricles and the atria aren't contracting on top of one another. All right, so it slows things down. Here's the thing. All right, our cardiac and the cardioinhibitory center can only decrease heart rate. It does not, I repeat, it does not decrease the force of contraction. Okay, so again, it's going to decrease the heart rate right here. If we're decreasing the heart rate, we're going to decrease blood pressure. And also, if you recall, cardiac output, that's why I like these equations. They help me figure out certain things. Cardiac output is equal to heart rate times stroke volume. So you can see how heart rate is affecting both according to these equations. All right. So if we decrease heart rate, we will also decrease cardiac output. And that's what it says right here. Decreases cardiac output and blood pressure. Just by looking at those equations, if that's something that's helpful for you. All right, real quick, I'll end here. Let me just get rid of this. Okay. The vasomotor center, okay? Remember, the only part of your autonomic nervous system that can affect your blood vessel diameter is the sympathetic nervous system. So the vasomotor center is only governed by the sympathetic nervous system. All right. So what we're going to see here, all right, we are going to see norepinephrine being released, okay, onto these blood vessels. Right, norepinephrine is our neurotransmitter here. Right, it's going to be released onto these blood vessels. Right, And what we'll see, depending on which receptors are activated, that plays a big role here. Okay, so we can get norepinephrine from the neurotransmitters, and then also we can get norepinephrine and epinephrine from the adrenal medulla, which is also stimulated by the sympathetic nervous system. Okay, so we can get it a couple different ways. We talked about this in chapter 19 when we were talking about, all right, the effects on the contraction of the heart here. Okay, so all right, we'll see that pretty much all or most of the blood vessels, all right, the smooth muscle cells have what we call alpha-1 receptors. And when we stimulate the alpha-1 receptors through norepinephrine and epinephrine, we will get vasoconstriction. Whereas others, okay, will have beta-2 receptors. And again, norepinephrine and epinephrine, if we stimulate the beta-2 receptors, we'll get vasodilation. All right, so that's really dependent on, this is the first time that you're hearing about the alpha-1 and the beta-2 receptors. All right, but point being is, all right, the vasomotor center is either going to cause vasoconstriction or vasodilation, depending on which receptors are being stimulated by norepinephrine and epinephrine. Okay, so here's what we're going to see. That sympathetic activation, all right, that comes from the epinephrine from the neurotransmitter, and also epinephrine, norepinephrine from the medulla adrenal gland there, right? You can get an increase in peripheral resistance because we caused vasoconstriction. All right, and that will increase our blood pressure. Okay, so that goes back to that one equation that I showed you previously here, okay, where BP is equal to HR, heart rate, times TPR, total peripheral resistance. Oh, total peripheral resistance. Resistance, wait a minute. If we cause constriction, that increases resistance. You're darn right. We've increased the total peripheral resistance, all right, because we've caused blood vessels to constrict. We increase blood pressure. Okay. And by doing so, when we cause that vasoconstriction, now we're going to move blood from our venous reservoirs. Remember, your veins act as a reservoir for blood. Okay, it'll sit there. Think about it. Right now, I've got tons of blood just sitting in my legs because I have not moved. All right. But now when I start to move, I am going to move that blood back into circulation. And guess what? I'm going to increase my blood pressure. All right. So in addition to that sympathetic activation, we're going to see, all right, blood going to your skeletal muscles and your heart because they're metabolically active. And we're going to see blood going less to other structures there. So obviously, all right, if we inhibit the nervous system, then everything will swing in the opposite direction. We're going to get vasodilation. We're going to get a decrease in blood pressure because we'll have, all right, more blood flowing. Okay, our total peripheral resistance decreases. All right, I feel like that's a good place to stop. I don't want to. I really thought I'd get through more. Of course, you know me, I have a tendency to talk. So that being said,